Have you ever seen a young patient with premature MI, normal LDL, no diabetes, no smoking, and still severe coronary disease? If yes, chances are you did not check lipoprotein A. Today, let's talk about lipoprotein A genetically determined, under-recognized, and practice-changing cardiovascular risk factor.
Lipoprotein A is an LDL-like particle with an additional protein called a polypoprotein A attached to ApoB. Lipoprotein A is highly atherogenic, pro-inflammatory, prothrombotic, due to structural similarity with plasminogen. Importantly, lipoprotein A levels are genetically determined, stable throughout life, and minimally affected by diet or exercise. Elevated lipoprotein A is independently associated with premature coronary artery disease, recurrent MI despite optimal LDL control, aortic valve stenosis, ischemic stroke, peripheral arterial disease. About 20 to 25% of the population has elevated Lp(a), but most remain undiagnosed. When should we measure lipoprotein A? Current guidelines suggest at least one lifetime measurement, especially in high-risk patients. Measure lipoprotein A if you see premature atherosclerotic cardiovascular disease, means less than 55 years in men, less than 65 in women. Strong family history of early coronary artery disease or sudden death. Recurrent cardiovascular events despite optimal LDL. Is severe aortic stenosis at a young age. FH phenotype with unexpectedly aggressive disease. This single test can completely change your risk stratification. Lipoprotein A can be reported in milligram per deciliter or nanomole per liter, which are not interchangeable. General interpretation. Less than 30 milligrams per deciliter, low risk. At 30 to 50 mg per deciliter, intermediate risk. A greater than 50 mg per deciliter, almost equals 125 nanomole per liter, high cardiovascular risk. The higher the level, the higher the lifetime atherosclerotic cardiovascular disease risk. What can we actually do? We don't directly target lipoprotein A yet, but we must treat the overall risk aggressively. Current approach. Aggressive LDL lowering, goal often less than 55 mg per deciliter in very high risk. High-intensity statins, even though they don't lower lipoprotein A. PCSK9 inhibitors, reduce lipoprotein A by 20 to 30%. Optimize BP, diabetes, smoking cessation. Consider earlier and more aggressive therapy in borderline cases. Niacin lowers lipoprotein A, but outcome benefit is lacking, so it's not routinely recommended. What's coming? This is where it gets exciting. Antisense oligonucleotides and small interfering RNA therapies like pelacarsen, olpasiran, can reduce lipoprotein A levels by up to 80 to 90%. Large outcome trials are ongoing, and lipoprotein A may soon become a treatable target, not just a marker. Lipoprotein A is a genetic, lifelong cardiovascular risk factor. Check it at least once, especially in premature or unexplained atherosclerotic cardiovascular disease. High lipoprotein A means treat overall risk more aggressively. Targeted therapies are on the horizon. Don't miss this risk factor today. If you're not checking lipoprotein A, you may be missing the real reason behind premature cardiovascular disease. Start checking. Start stratifying better.